just reading.
Holy moly.
I think we have people on the phone who should be able to hear us in the room at this point. All right, everybody, we're going to go ahead and get started. I'm going to pace the room, and that's my call to order. I know that there are still a lot of name tags in the back and that people will probably be trickling in, so we're just going to have to tolerate that. I think it's difficult coming downtown. Traffic was a little nuts. Parking is always challenging, so I'm sure that there'll be others joining us. We do have some people joining by phone this morning, so we welcome you. And I can click back to our instructions. For those of you that are joining us by Zoom, we're happy that you're here, and you can unmute yourselves to join the discussion. You can also chat into the room. Emma will be monitoring the chat on Zoom so we can see your questions and comments there, and she can share them with the group that way as well. I know that when there's lively discussion, sometimes it's hard to jump into the room. If you want to speak, sometimes letting Emma know that you're poised and ready to go can give us a cue to pull you up and give you a turn. So if you're joining only by phone, just don't forget that the mute function for Zoom is *6 to mute and unmute. It doesn't really work if you just mute your phone the way you would any other time. So just please make sure that you're muted when you're not talking so we don't get a lot of background noise. So welcome, everyone. My rapid Zoom instructions. And I'm going to pass to Michelle just to say hello, kind of get us grounded in the day, and do some quick introductions around the room. There you go.
I was looking for something high tech and it's just a button.
Oh, one more reminder before Michelle goes. We have a couple of mics that are really helpful with room, and I will try to pass them as much as I can so that we can use them. They're helpful for you all. They're also very helpful for those on Zoom. But these are pretty sensitive to picking up sound, but not if you talk real soft. So everybody needs to speak up so that they pick up our voices.
All right, I will speak up. I'm Michelle Barnes. Welcome to our main task force meeting today. I am very excited. I've been participating and listening into a lot of the subcommittee meetings as well as participating in the main task force. And I can tell you momentum is growing. So Jen and I were just talking about this task force hasn't really got into the meat of it yet because the subcommittees have been getting into the meat, and they're going to report out today a little bit on what they're doing. So this is when it's game time for us. So I'm glad you could all be here today, and I know people still trickle in. I also want to mention we've done 2 public testimonies since we last met, and quite a few of you have participated either in person by phone. They are powerful. I don't know how else to say it, but I really want to encourage you personally to try and attend 1 or 2 or all of them, or as many as you can, or listen in for a short part of it. The comms team is also, we took videos of everybody who presented, and they're putting the videos, people who were willing to. We've been putting those videos online. So if you go to the website, there's some amazingly powerful videos that I can't tell you how much it's going to make you grounded in the work we're doing. They're really important that these people feel heard and that we hear their stories. So I really encourage you to take some time and just watch. They're about 5 minutes each, and there's probably 25 of them now. So
yeah, well, we can try. We have a video to share today.
Yeah.
Do you want to do it now, or you want to? All right.
Okay, let's do it. Since I mentioned it.
This is always how you know if the facilitator's on her toes. Can she find the video? Here we go. Come on, play the video. I'll get out of the way.
back on. That was a great example. We heard about 25 stories just like that. And John's been there, Nancy's been there. Who else has been to one, listened in? Quite a few of you guys have. Joe has, Nancy. Yeah, that's right. Nancy was there, Meg was there. These are really powerful stories, and I want you to all hear them and let them settle in your heart, because this is why we're doing the work we're doing. I will say not all of them are depressing. Some people have come in to say what's working in the system. There's some shout outs. There's some recommendations on things we should keep doing. The Lieutenant Governor was at the last one. There's a lot of depth in these testimonies, so I really encourage you to spend some time with them. Before we start today, we're going to do very quick introductions. We do have a couple new people, so if you're new and haven't been to one before, you can say a couple extra sentences. But why don't we just start by saying who you are and who you're representing and where you're from? Would be helpful. Would you like to start? I think you come from the furthest away today.
Good. Well, good morning, everyone. My name is Selwyn Whiteskunk, and I'm with the U-Value Tribe, U-Value Tribal Council member. I'm glad to be here.
Good morning, everyone. My name is Glenn Most. I'm with SCL Healthcare and West Pine Behavioral Health.
Hello, I'm Patricia Oliver with Oliver Behavioral Consultants, and we're providers for individuals with developmental disabilities mostly.
I don't think the microphone's working.
Let's go.
The microphone is working. I was just speaking into it. I think it should be, if you.
Testing. The light is on. It's a curtain.
So mics, so just project.
Yeah, just talk loud. We'll see if anyone was formerly a kindergarten teacher.
You can do it, Daniel.
Hi, I'm Daniel Darty, not a former kindergarten teacher, but with Signal Behavioral Health Network.
I'm Jill Dario, and I'm out of Grand Junction, and I'm with Mesa Youth Services.
Tracy Krafthardt, State Representative.
Nancy Vandermark with Mental Health Colorado.
John Laukinen with Healthcare Policy and Finance.
Nancy Jackson, Arapahoe County Commissioner, and forgive me, I'm gonna have to step out for a minute, but I'll be back.
Nancy Ingalls, Douglas County School District. Michelle Broder with the Department of Corrections. I'm here on behalf of Dean Williams, our executive director. This is the first time. Kristen Bates, Department of Healthcare, Department of Human Services.
Not yet. She was
Today, behavioral health.
Harding, Office of Behavioral Health. Hi, I'm Ashley Dunn. I'm Dora, and I'm here on behalf of our Executive Director, Patty Salazar.
I am Debbie Oldenettle. I'm with the Colorado Department of Public Safety, and I'm here on behalf of Stan Hilke, our Executive Director.
I am Jill Ryan. I'm the Executive Director of the Colorado Department of Public Health and Environment.
Michael C. It's got a gremlin.
How's it go? So there we go.
I
I know, that happens sometimes. Mike Conway, Commissioner of Insurance.
He's really powerful. So I'm Diane from the Lieutenant Governor. Kim Nimstover, Executive Director, Healthcare Policy and Financing. Michelle Barnes, Executive Director, Department of Human Services. Jen Fanning with the Grand County Rural Health Network in Grand County, and represent Northwest Colorado. Neil Epperson from the CU Anschutz Medical Campus and the Department of Psychiatry and Pacific.
Deidre Johnson, I'm the Executive Director for the Center for African American Health.
Shannon Van Diemen, Children's Hospital, Colorado.
Hopefully the microphone gremlin has gone away, because we need this microphone all day. I'm Stephanie Kirshner. I'm with the Farley Center. I'm here with Emma, Jonathan, and Pooja to facilitate the process today and make sure we get all the notes and all of the takeaways to incorporate into our work moving forward. So we'll go to Zoom real quick too.
So for those on Zoom, just a reminder, you can unmute yourself through your computer or by *6 on the phone. So task force members that I believe are on Zoom, if you want to unmute and say a quick hello, is Meg Taylor. That's a hello from you, Meg. Let's try Laura Ticho. We're not hearing you in the room, so just double check that you're unmuted.
Morning, everyone. I'm Kate McCrory. I'm with the Colorado Department of Agriculture.
Hi, Kate. Becky Ela?
Yeah, good morning. This is Becky Ela. I'm from Delta County Memorial Hospital, and I want to shout out to Jill, who is a fellow Western Sloper who made the trek to Denver.
Hi, Becky. And Della Cox-Viera.
Yeah, this is Della. Good morning, everybody.
And are there any other members of the task force on the phone?
Yeah, good morning. This is Raul de Villegas from Grand Junction. I'm with RDB Executive Consulting.
All right, I'm going to take a moment to welcome the members of the public who have taken the time to make their way to join us today. Thank you for being here. And I know that we'll have more subcommittee members probably trickling in, but Barbara, you want to do a quick introduction?
Barbara Drake from Douglas County, a member of the executive committee. Excuse the tardiness, the traffic was very bad coming from Colorado Springs.
That's okay, we understand, we've all been there. Did anybody else come after we started intros?
Brian Turner, Solvista Health, and I just excuses Barbara.
Rita Gonzalez, Forensic Services and WINS. Wait, is that everybody? We also have the communications team from CDHS here. Summer's here. So welcome, everybody. So our objectives for the day are to answer some questions related to the legislative review that was sent to the committee for review. We're going to hear from the subcommittee co-chairs, and they're going to give some updates and some counsel from the task force and their work to date. We'll have an opportunity to do an introduction of a timeline that we're creating to kind of look at work moving forward and look at a continuum framework that we're trying to start building the work of the subcommittees around, and then have a discussion related to that continuum and the barriers that you all identified in the survey that you completed since the last meeting. One other piece of housekeeping for the men. There's a badge that you'll need to go to the restroom if you need to use it. You go out to the left, and then you need a badge to get back in through the door. Youngshin has the badge. And the ladies' room is kind of past the front door where you came in and around to the left. All right, and then we just need to approve the meeting minutes from August 7th, which hopefully everyone's had an opportunity to review. So is there a motion, or after review, are there any revisions or updates that anyone wants to suggest? Go ahead, Brian.
I just didn't have a chance to review after I had sent some revisions, so I don't know if Summer, did they get incorporated?
So we included a copy of Brian's suggestions for revisions with your packets that you have in front of you. So that would be minutes with those changes and any other changes that people want to propose.
So essentially, I just corrected some of the names of the organizations that were cited as some good examples of where the 6 visits in primary care for behavioral health are occurring. And then the last one, I think, was just a correction on the name of the representative or the organization that the representative was from. That's it.
Thanks, Brian, for catching that.
I'll make a motion.
Second.
Okay, great. So we're good to go with the minutes approved. If you came in late and need materials, they're over here by the window. I can help you get them in a second once I pass the microphone. And then I guess to Summer, she's going to talk a little bit more about the community visits that she's making across the state and some of the public hearing. Please, for those of you that are joining me at the front of the room at any point today, be careful of cords. We tried our best to get them out of the way, but it's a little tricky.
Good morning, everybody.
Good morning.
Let's try that again. Good morning, everybody. There we go. It is great to see you all here, and thanks again for your time and commitment. I know we've been sending you lots of information and really appreciate that. I just want to spend maybe 40 seconds just talking to you about the community conversations that we have been having. We did circulate the survey of what we've heard so far. We will continue to update that kind of summary of the community conversations on a monthly basis, because I do think it's important for you all to hear what we're hearing from stakeholders and providers and family members and consumers from across the state. So that was circulated in one or more of the emails that you've gotten recently. It is also on our website, on our webpage, which we will also continue to, again, upload on a monthly basis. Just a quick summary of some of the major themes that I think that we've heard so far. One is lots of enthusiasm and hope. I mean, people are really, I think, excited about the work that we are all doing. They're also really excited about the fact that when we talk about the blueprint, it's going to have the public policy, the budgeting, the staffing, the accountability piece. So really kind of sets itself apart from some of the other reports that have been done over the years, which are really helpful in informing the work that we're doing now. So just that hope and that enthusiasm has been really great. I think some of the things that people really have questions about or want to see differently, not surprising, access. So no matter where you live, no matter what your income is, no matter what your status is, people want to just be able to say, I just want to have access, and I want to have access when I need it. So no big surprises there, but that is, of course, a big theme that's come up. Medicaid and reimbursement rates, lots of questions around that. So that has come up several times. Sharing info among agencies. So how do we respect HIPAA and at the same time find a way to allow partners and providers to communicate with one another about some of that important patient information that could be really helpful in getting that person help even sooner. And then finally, another big one is workforce. And of course, making sure that we have enough of workforce. But then the other big theme around workforce is making sure that the workforce we have is adequately qualified. So I've definitely heard some stories of, you know, we've got one person who can provide services in our community, and they're not that great, but it's who we have, and there's nothing we can do about it. So those are some of the themes that have come up in those conversations, but definitely encourage you to kind of read the summary of the community conversations, because I think it will help inform our conversations that we're having here, and give us kind of some major themes to be thinking about. So I just wanted to kind of put that on your radar. We had a training last month that has been recorded. We've also circulated the links to that. We tried to make that as easy as possible. So if you want to have your own community conversation, you have all the materials. You have the handouts, you have the questions to ask, you have the checklist, you have the email communications to send. So we really tried to make it an easy lift for you as possible so that you feel comfortable facilitating those conversations in your communities, and really encourage you to kind of team up with other people in your region or community or area so that you're not doing it solo and you have a chance to spread the wealth amongst the facilitation. And then the other thing, just as Michelle mentioned earlier, just participating in the public testimonies, whether you're listening, watching virtually, or in person, they are really powerful. And it is a good reminder of why we're all sitting around the table, why some of us are up late at night, up early in the morning, just doing the work that we do. And especially because there's so many of us sitting around the table who don't have that face-to-face interaction on a daily basis because we're more at the management or executive level. Those testimonies really bring home, here's why we're doing what we do. So I just want to encourage you to do that. In your packets, you've got a list of the testimonies. Dates, Michelle's going to be down in Durango first week in October, so we're going to do some public testimony down there. We're working on getting something set up in Grand Junction in October as well. So really trying to make sure that we hit all parts of the state. We've got the opportunities listed, and really encourage you to push this out to family members, people with lived experience. Those are the stories that we really want to hear at the public testimonies. So thanks everyone, and I will hand it back. Oh, actually, I will hand it to Kristen. So Kristen was kind enough to put together the legislative review that we circulated. We also asked all of you what are questions that you have after reviewing the review. So we want to kind of just ask Kristen to give us a quick update, address some of those questions, and then maybe have a short conversation. We're making the most of her time while she's at OVH.
Well, good morning, everybody. Thank you so much for giving me the opportunity to talk with you about some of the policy basics, as my understanding is that this group is going to be preparing some policy recommendations in the next few years. I'm sure this session, as well as the sessions to come. So I started off by preparing this. Again, my title is Director of Strategy, Policy, and Communications with the Office of Behavioral Health. I am moving over to HICPUP on Monday. This is my last and final meeting with OBH. So I've learned so much about behavioral health policy in the past 3 years, and wanted to go over some of the things that have happened and some of the things that haven't. So the first page, if you guys take a look, it really is just about making sure that everybody is on the same page as far as the care continuum goes. You know, this the half circle, the blue and white, is really about among the care continuum. A lot of the work we do around behavioral health either serves everyone, you know, health promotion, helping promote healthy behaviors, moving on to prevention of behavioral health crises. When somebody might have indicated that they have a behavioral health disorder, making sure that they have some preventative care as well as treatment. And then following acute treatment or more intensive treatment, there is a long period of time that a lot of people spend in recovery where they're maintaining their behavioral health disorder. Below that is this stoplight kind of pyramid that I've got here. And this is really more closely aligned with the treatment part of that care continuum. I thought this would be a helpful way to understand both mental health and substance use and how an individual could move from a period of crisis where they need stabilization services down to a level of maintenance where they need just standard community supports. So you can see on the little pyramid, there's the different levels of acuity that an individual might go through with their behavioral health disorder. And then on the right, there's a list of the types of services that are going to be available. And I encourage all of you, when you're looking at your policy recommendations, to see if there are any gaps as you make these recommendations. Where do we need to improve? Where do we need to continue and expand? And when you finalize everything at the end, to maybe take a look and say, did we hit everything here that needs to be hit? So if you look on the next page, I've got this kind of chart, and I even did a little bit extra work on this so the font's even smaller. I apologize. There's just so much to put in here. This is kind of about the statutory authority that our state agencies, this is where policy lives in the state of Colorado. And there's really 4 agencies that are primarily tasked with behavioral health as a large part of their effort. That would be the Office of Behavioral Health and Department of Human Services, really the Health Cabinet, the Department of Public Health and Environment, Healthcare Policy and Financing, and the university under the Consortium for Prescription Drug Abuse Prevention. I tried to kind of give some examples of duties that they have along that care continuum of prevention, treatment, recovery, and harm reduction as well. And I think I'm going to try to go through some of these questions as we go through this. One of the questions we got was about the spaghetti funding, how we have all these different opportunities for funding and all of these different directives. And I think that this is an area where there is absolutely some opportunity to do a good job in aligning. I think that something that's worked really well recently is groups like this. It's that matrixed communication that we have across departments that helps prevent duplicative services. It helps us also bolster each other's work whenever I do something and then there's somebody else who can promote that work. So helping to promote the work that each other that each other department does. But I also want to say at the beginning of this, I highlighted that behavioral health also lives in the Department of Education, the Department of Corrections, the Governor's Office, the Department of Public Safety has a huge behavioral health part with facilities and with Safe to Tell. We also have the Attorney General's Office, which has really dedicated a lot of time and effort to behavioral health. And I would encourage you all to look at the opportunities to reduce duplication and look at opportunities to improve maybe the lanes that we all go in. But it's not always about duplication. To me, this shows integration. And I think the integration of behavioral health into all these different departments is really essential. I think that centralizing everything to a certain extent, well, first of all, it would take you guys years to untangle the policy. But second of all, I think that it's important that each of these departments recognizes that behavioral health is an essential part of human services. It's an essential part of social services. It's an essential part of education. And when we look at changing the policy, there's the opportunity to kind of move everything into one direction, but we also have the opportunity to say, how do we unduplicate? How do we encourage each other to partner without removing behavioral health from some of the areas where it's really essential? So I think that that would be kind of my answer to that question. I think the other answer to the question about how do we address all these different funding streams is setting expectations that the federal government sets a lot of these funding stream expectations, and we might have to follow those. So some of this is going to remain. Even if we could detangle as much as possible, there's still going to be some federal government that pays $40 million to the Office of Behavioral Health for block grant every year, which is, we're not going to question too hard on what it takes to get that funding, because 95% of that money, we have a 5% limit on our administrative costs. 95% of that money goes out the door into the community. So this also kind of goes into the statutory breakdown. So I thought it would be helpful for you guys to get a little bit of an understanding. Yes, I'll pause for a second.
Will you just mention the role of the counties and local governments in this? Because this is talking really at state level, but there's a lot of heavy lifting happening there too.
Absolutely. And I think that local counties and municipalities really in the past few years have stepped up, not just through their local task forces and their local coalitions, but also putting their money where their mouth is and putting tax money into this. And so I think that that's been a huge part, and none of these are going to work if we don't have the partnership with the local people who are actually doing the work.
You highlight the major departments, but Colorado Department of Labor and Employment also plays a big role because they have vocational rehabilitation in their department.
Housing.
Yeah, housing, higher ed, also because they educate all of our professionals, and Dora, I don't know if you mentioned Dora, because they license all of our professionals. So
Kristen, can you repeat the question for those on Zoom before you answer?
I just want to make sure when we're looking at the spaghetti chart of who's funding what, we make sure we gather everybody's information.
Absolutely. The Lieutenant Governor and Nancy Vandermark highlighted that Department of Regulatory Agencies, Division of Housing under the Department of Local Affairs, and the Division of Voc Rehab within the Department of Labor and Employment. All of these, there's so many places where this is going to have overlap.
And I would say maybe add under the Department of Human Services, the whole child welfare system as well, that spends millions of dollars on mental health and substance abuse as a combination, obviously, of local, state, and federal funds.
Absolutely.
It's going to be a very good chart.
I'm going to make it even smaller for you guys.
That's the problem.
Yeah. So for the statutory breakdown, again, what you're going to find is there's a lot of different places where you're going to see behavioral health. Again, the housing vouchers that have recently come out for both people with mental health disorders and last year substance use disorders, living in recovery. There's obviously healthcare policy and financing has a lot in what they pay for and what they measure. Department of Public Health and Environment on what their surveillance looks like and what their data looks like, as well as prevention, which is a huge part of their work. But there is one part of our statute, which is Title 27, that is dedicated entirely to behavioral health. And I wanted to give you guys just a quick rundown of some of the things that are in there to help you if you're looking for kind of where it is that you want to change. What are the changes that you want to make? So one of them is 2765. This is going to be familiar to some of you. You might equate it with the process of a 72-hour involuntary hold. Some people call that a 2765 hold. Some people call it an M1 hold because that's the form that you fill out for the hold. And it's in statute, it's a 72-hour involuntary hold. That's what it's called. But the 2765 goes through that involuntary process for the 72 hours. After 72 hours, if somebody's evaluated and they need to continue treatment and they're not willing to continue, they can go through a court process to maintain involuntary treatment for up to 180 days, and then that's a short-term certification and then long-term certification. But this also includes voluntary treatment is in here and patient rights. There's a lot of things in 2765 that are really important to how we treat people with dignity who have mental health disorders. And I would imagine that it would be really tough to make significant and bold moves in the area of behavioral health without taking a look at what 2765 has in it and how we can improve it. I had a question about what we purchase. What treatment and interventions do we pay for? I would need, I could read you guys our contracts. It would take a few hours, but I thought that it would be easier to take a look at Title 2766 and Title 2780. 66 is mental health purchasing, and that's where we define what is a community mental health center, what is a community mental health clinic. That's where we define what services they're required to provide and what services and what quality standards the Office of Behavioral Health provides. These are the two places that give us authority to do licensing, and we call it designation for mental health for providing this 2765 service, that involuntary hold and voluntary treatment process. But if you all are looking at, again, the procedures that somebody goes through when they're in a crisis, 2765 is that place. If you're looking at what we purchase and what quality standards we require and what else we have in here, what is exempt from the purchasing code, because we have our procurement code that we have to follow through this whole long process. But there's a lot of things that the Office of Behavioral Health and our other partners can purchase that are exempt from that code when it comes to behavioral health. So it gives an example of kind of what we can purchase and what we expect from the people that we purchase from. And it gives us the authority to have oversight over them from a regulatory and statutory standpoint. The other two sections that I think are pretty important, 2760, I missed at the very top because it's so small. 2760 is the crisis response system. There's also some information in there about outpatient forensic services as well as jail-based behavioral health, which is becoming increasingly an area of success for Colorado. Still a long way to go, but we've had a lot of investment and expansion in services in jails. So that's 2760, and that's a pretty new statute that's just been around for the past 5 years or so. And then finally, something really interesting about Colorado statute is that alcohol and substance use have separate chapters. They have separate articles. So this comes from the history of the connection between criminal justice, alcoholism, and the things, oh my gosh, the things that we took out of this statute, the offensive language 2 years ago was really great. But there's been this history, this criminal justice history of how we really started to provide treatment for people with alcohol use disorder and substance use disorder, and they came up separately. So we have separate statutes, and I will say that the interim study committee for opiate use disorders and other substance use disorders has multiple recommendations to combine these two things. Oh, did we have a pause? Do I want to pause there?
Sounds like someone might be. I think you're okay, Kristen.
Okay.
We've been getting, someone's not muted maybe on their phones. If you could just check if you're on Zoom to mute.
We've sort of done away with the term addiction, I believe, but once upon a time, and Nancy knows this very well, when I was in the legislature, one of the worst addictions you can have is gambling addiction. And we have lots of gambling in Colorado, but we put like zero money towards gambling addiction treatment. We have a hotline that's answered somewhere out of state, and I've tried it and it really doesn't work. So how do we incorporate, because in the research I did, gambling addiction is one of the worst. If it's not the worst addiction, it's one of the worst addictions, because you lose your job, you lose your home, you lose your family, you lose your everything. And there's really no treatment for that. So somewhere in our conversation amongst this big group, we need to incorporate gambling addiction. And if we're not using the word addiction anymore, I don't know how we capture that. I just wanted to flag that.
Yes. Yeah, thank you. I do have a lot.
Here, Nancy, I'll give you this.
I wasn't a kindergarten teacher, but I teach. I have I do have that place. Just so you know, we do at Rocky Mountain Crisis Partners, they do have a gambling hotline, and I do believe, I would have to double check that the state is partially funding that with the crisis system. But if it's not effective, then we need that feedback so that we can make it better. So can you just tell me when you called? Was it recently?
Legislation years ago, and it probably is part of what created that
Okay.
aspect of the hotline.
Okay.
What we were trying to do is train professionals to deal with gambling addicts. It's a whole different type of therapy.
Okay, a training program, which.
And that kind of, well, it's a long story, but it flopped. And so now we have this little piece of the crisis line.
Okay.
But it's just something I
But
think
we need to expand that.
as we move forward, we need
Perfect.
to have
Got it.
professionals that can treat gambling addicts.
Yeah, thank you. And I will say we actually had legislation last year to study what we're doing with your legislation that you put through. And we have a draft in queue right now, I believe. So we should have a study to share with you all in the next couple of weeks. All right, so the last thing, and I think we do need to wrap it up, but the last thing is, I wanted to make sure that everybody understood that there is a process by which you can be involuntarily committed for substance use treatment. And that is a big part of what is in the alcohol and substance use disorder statutes. And if I pulled some numbers last night, and about 39,000 people were reported to the Office of Behavioral Health as going on a mental health hold. Or sorry, there were 39,000 holds for 34,000 people last year. And this does not include people who are put on hold in emergency departments who don't report to the Office of Behavioral Health. So that number is probably grossly inadequate. Last year, we had about 110 people that went on a substance use hold. Now, I'm not saying one of those is right and one of those is wrong, but in 2013, there was a civil commitment task force that did make some recommendations around this. Somebody asked me about things that have been recommended and not passed. I think you all have done a really a really good job of taking things that didn't work one year, fixing them, doing the stakeholder engagements that's necessary to get them through the next year. I think about, forgive me for mentioning it, Senate Bill 18252 that became Senate Bill 19223 this year for people who have need services in the forensic population for competency. So that was one that was tried to go through and really hasn't been revived, and I think is going to be revived this year through the interim study committee. But I do think it's important to understand that there is an involuntary process for substance use disorder, and a lot of people really separate the way that these are done, and it's worth taking a look at how they could be better aligned. And then if you want more information on, this is just the big ones that passed in the past 3 or 4 years. There have been, last year I think we tracked 110 bills for the Office of Behavioral Health that had behavioral health involvement. So, so this has been obviously a real priority for the legislature, and I think that we have a really great opportunity to be aligned and partnered in agreement and consensus on some legislation this year. I think we have such a well-educated legislature that would be really prepared to make some thoughtful, bold, and well-informed changes.
We have time just for a couple questions, and then we're going to move into how we can start applying some of this to the work of the subcommittee. Yeah.
Can you ask people to say their name?
Yes.
As they're speaking, so that people on the phone know.
In case you didn't hear Summer, please say your name before you speak so that people on the phone know who's talking to you.
Hi, Nancy Vandermark. Kristen, the 110 number, is that just involuntary commitments, or does that include emergency commitments, short-term commitments as well?
That just includes involuntary commitments. Emergency commitments are up to 5 days. They're put on through a detox process, so it's kind of a forced detox. And then for people who need treatment, detox or withdrawal management, as a reminder, is not treatment. It's a stabilization process. So for those who actually go into involuntary treatment, it's about 110 people per year.
But the 39,000 is
mental health.
So short-term and long-term.
Short-term and long-term.
Jen Fanning, I really want to underscore that involuntary substance abuse, we've tried to train our providers multiple times, and there's just such resistance to even doing that. I don't know why. So I think that that's a really big opportunity to figure out how to get that out to the providers. And then secondly, I really want to lift up an opportunity that I think is really important. It's really impacting our rural communities with crisis system M1 holds and possibly the program purchasing is lack of ability to pay for transportation for M1 holds to facilities. We're spending thousands of dollars every year. We can get people back, that's not an issue, but getting them there, there's a glitch in the current policy and payment that it's not emergency and it's not non-emergent because they have had their rights taken away. So we can't actually get Medicaid or insurances to pay for those individuals, and it's taking a tremendous amount of time and effort. It's not happening anymore. I think because the hospitals are getting a lot better at understanding that, but we used to lose beds because we couldn't get transportation. I think we're getting a lot better at understanding that, but that's a really tremendous opportunity for us.
Yeah, and it was something that came up in the barriers for sure that you reported in the survey that we'll have an opportunity to kind of really dig into and think about what this group feels like they can really prioritize and tackle. I'm hesitant to, I'm going to look to Michelle.
Yeah, go ahead.
Okay.
Then you don't get a bathroom break, people.
Well, you have anyway, so.
That's a lot of responsibility.
I'm not giving you a break.
Okay with that?
If you have to go, just go.
So the treatment pyramid on the front page, I think you did a great job with this. One thing I would just point out, and you're moving on, Kristen, so whoever replaces you, but having detox under the crisis services box versus inpatient, I think a significant number of detoxes occur on hospital medical floors across the state. And so, again, I think it can be seen as crisis, but also a significant number on the outpatient side as well. So, thank you.
I would rate just quickly, are you able to track the number of M1s across the whole state? And I also wanted to ask, are you tracking M.5s?
And yes, thank you so much. Last year, we actually, 2 years ago when we passed, 3 years ago, 17207, it actually required that hospitals report to the Office of Behavioral Health the number of M1 holds that they get every year, and the response to those if the person is released or if they're continued on a hold, and to track the transportation holds. We just got our first batch of data July 1st, and I think that is being still in the analysis process. It's a lot of data, but we're really excited to present that because I think it's going to give us a whole new picture, because we've never had the whole picture of how many people have done this. So it's going to give us the whole picture finally for the first time in Colorado history of how many people are on hold, where they come from, what happens to them when they finish, and how many are coming in through a transportation hold process.
I think it's really important because I believe that those M1s are associated with the concept of the revolving door of people going to a hospital, getting released, and then not being effectively connected to ongoing services.
I'm coming to you.
Yeah. Debbie Oldsmetal with representing the Department of Public Safety. I think this goes without saying.
I'm not sure that it is. Here,
I'll just talk about I can just try to really yeah.
Debbie Oldsmetal representing the Department of Public Safety. I think this goes without saying, but on that front chart, I agree. I think you did a great job representing the pyramid of services for people who aren't as familiar or as educated about mental health issues. I'm curious if you can also, again, this is minor, but put a line going up so people recognize if services aren't delivered at that bottom part in terms of the prevention, how they move up the pyramid as opposed to, and again, minor change, but.
Yeah, I considered making it inverted, and I think either way it really works. It's like you need a little stick figure on it to show that this is how somebody moves through care, and that these are essential supports to prevent that crisis.
I just want to make one quick comment, and then I promise I'll give it back to you. I think it's really encouraging that we passed so much legislation last year, and that absolutely shows that the legislature and the broader communities are paying attention to behavioral health. I would also just like to point out that each one of these, while incredibly well-intentioned, has the potential to continue the layers and layers of complexity that we observe on the previous pages. So I would just hope that we can think about quality over volume, or think about doing what's the major systemic changes we can do rather than a whole lot of different quick fixes things.
I'm going to give Deidre the last word here, and I would encourage you, if there are further questions, to put them in parking lot stickies, because we can also get these to Kristen or whoever is stepping into Kristen's position to make sure that further questions get answered.
Thank you for this very thorough overview. When you mentioned the M1 data that's forthcoming, curious if it will include age as well as race of the folks?
Yes.
Will be disaggregated?
Yep. And gender and geographic position of the patient and of the provider who's doing the whole.
I know that there are a lot of questions, and I appreciate that. I think what I'm feeling, though, is in my comfort in moving on, is that some of this conversation and how this legislation applies, what we're going to do next, can come out of some of the group discussions that we'll be able to engage you in. And then the questions that are very specific around the legislation, we can get back to Kristen and her team through email. So with that, I'm going to move into updates from the subcommittees. I have to say, as Allison, I hope you can hear me, is unmuting, because she's going to go first and report back for long-term competency. These subcommittee chairs have been fantastic at getting these groups of incredibly opinionated and intelligent people rowing together through the first couple months of their meetings. So I just want to say thank you from the Farley Center to them for working so hard with us to get this all moving. And I know that they're excited to share with you what they've been doing and hear back from you. So Allison, and I think Summer, you're gonna back up a little bit. Allison, can you hear us?
I can. Can you hear me?
Yes, thank goodness. I will advance slides for you.
Fantastic. All right, so this is Allison Butler. I am the legal director at Disability Law Colorado, and I am co-chairing the Competency Committee with Robert Werthwein. We have been incredibly active. We've already had 4 meetings. We are meeting every other month, and we just expanded the time that we're going to be meeting, generally from 2 hours to 3 hours, and we're also adding 2 half-day components. We're really working hard to get through the plan. We did start from a different place than the other subcommittees because part of the function of this particular subcommittee is to come up with a comprehensive plan for Colorado to address the competency issues. And because of the lawsuit that was filed by my organization against CDHS and the consent decree that everybody agreed to, that plan has to be submitted to the federal court in January of 2020, so just a couple months away. So CDHS had a draft proposed plan, and what the subcommittee has been doing is working through it during this time. And we are going to be working specifically through that plan until the end of the year. After the end of the year, we will, in the new year, we will be starting to look at other things like prevention or other tangential issues that affect competency, but right now we're focused on that plan. So on the next slide, I just wanted to let you all know sort of how we're working through the plan. We are looking at an Intercept model. This is something that's been used by other states and is really looked upon as a good way to compartmentalize the different things that need to happen within the competency spectrum. So in this Intercept model, Intercept 0 is community services, so what needs to be happening in the community so that people don't even get into the criminal justice system. Intercept 1 is law enforcement. What kinds of things can we be looking at in law enforcement to have diversion on the front end, to have better training or additional resources for law enforcement. Intercept 2 is initial detention and court process. So again, can we be looking at diversion? How can we be identifying people who may have competency issues from the very beginning so that they don't have to wait in the court process or in jail for 4 months before it's even identified that they may have a competency issue? Intercept 3 is competency evaluation. So literally, how should the evaluations work? Who should be performing them? What type of training should they have? What things should they be reporting about? And much of this is also impacted by Senate Bill 223 that was passed in this past legislative session. So we look at that in conjunction with our Intercept. Intercept 4 is restoration treatment. So once somebody has been found to be incompetent to proceed during court, then what should that restoration treatment look like? Where should that be done? How can we make it the most effective and also person-centered? Intercept 5 is discharge. So once somebody has been deemed competent to proceed, how do we get them out of this system and back to face their criminal charges, and how do we get them out of the hospital? How do we get them out of jail? And on the next slide, I think we have, okay, so that's all of our intercepts. We started with Intercept 3. We've done 3 and 4. Next Monday, this coming Monday, we're going to be working on some of the past things that we've already done and trying to get to Intercept 5 we're finding extremely rich discussion among the subcommittee members. And so it's, you know, we, I guess, sort of hope to breeze through things, but that really probably isn't what we should be doing. And so we're taking a step back to say, let's try to incorporate all of this feedback and make this plan the best that it can be. One area where we have struggled a bit is with consumer feedback. Of course, the meetings are open. We don't have a ton of people attending from the public, and when they do, they rarely speak at all. And we just haven't been getting a lot of, I don't know, feedback in between meetings either. We are trying our best, and we intend to have either a consumer panel or a whole meeting devoted to consumer feedback. We do have 2 folks on the subcommittee with lived experience and 1 parent. So we're really trying, but if the overall task force has ideas on how to better solicit that feedback, we're absolutely open to it. We are also going to be taking a trip down to Pueblo, the SimHip, and some members of the subcommittee have expressed an interest in going to RISE, the program out at Arapahoe. There's a new one at Boulder, but Arapahoe has been up and running for a couple years, so maybe go and see how they're doing. Generally, the feedback is that they're doing a pretty good job. We're also going to be examining whether there are other legislative efforts out there that may complement or help the things that we're looking at. One of those is there's talk right now about doing a bill to defelonize symptoms of mental illness or other intellectual developmental disabilities, specifically if there are assaults by somebody who's in the midst of a crisis, whether those could be misdemeanors rather than felonies. Definitely still working through that, and it's going to be up to the subcommittee if they want to formally address those. And then by the end of the year, we're going to be finalizing our recommendations for the plan. So we've got a lot of work cut out for us between now and December.
I just want to say that this has been a subcommittee that is not afraid to roll up their sleeves. They've already scheduled, I think, 2 extra meetings. We're going to go to Pueblo. Like, it's really been a really proactive group of people. So again, thank you for that. Are there questions from the task force? Back to Allison.
Hi, Allison. It's Barbara Drake from Douglas County. My question is, do you have a county attorney on your committee?
Do we have a what? I'm sorry.
Attorney. What I'm going to suggest is, if you do not, maybe we could put some questions out to the county attorney's listserv, because they are doing a lot of this work in the jails in terms of the competency hearings. So, and working with the sheriff's office and other co-responder programs. So, excuse me, if you don't, I would be happy to send you information about the county attorney's listserv and can get some feedback from the county attorneys across the state.
Well, I think I'm going to say yes to both, because I do believe we have a county attorney from Pueblo who does these types of hearings, but I don't know if she has been sending that out to the listserv, and I think that would be great input.
Okay, good.
Hi, this is Diane Provera, and I didn't eat breakfast this morning, so I don't know why I'm so talkative, but yesterday I went to an OE High meeting, and I want to compliment, I forget what your name is, Neil. I heard one of the best presentations about how people wind up in the criminal justice system who have mental health problems. So now tell me if you've got this right, but if somebody's having a crisis at home, they call 911. 911 is not hooked up to the crisis hotline. 911, the dispatch people don't really know about the crisis hotline. The person may or may not have done anything criminal at that point in time. They might just be out of control. But 911 calls the police. The police go to the house. There's been a 29% uptake in assaults against police officers, which puts them in the criminal justice system right there. And so if somehow or other this group and all of us could figure out a way to fund or connect 911 to the crisis response group and send out instead maybe an EMT and a mental health worker,
as opposed to a police officer. They wouldn't begin their journey towards the criminal justice system and competency restoration and all that kind of stuff. So I don't know if I captured everything that you said yesterday, but I think your partner and you should either do a presentation to this committee or to the long-term care competency committee, because I just thought that was one of the most powerful aha moments that I've had in terms of how people wind up in prison.
That sounds absolutely amazing, and that's exactly the kind of thing that we're looking at for the Intercept with community and with law enforcement. And I was just talking to a consumer yesterday who relayed almost exactly that same kind of story, and a friend of hers was in a major crisis, was at home alone, but when he called 911, the police came, and he ended up being charged with felony menacing. And so I think it could have been handled a lot differently. I think people, A, don't know what they can do to set up better systems in their community, and B, may not have the resources. And I think that is the task of our subcommittee to help those things happen.
Thank you. This is Nancy Jackson, Arapahoe County. After Lieutenant Governor Rivera's comment, I have two things. One is that not only does that happen when the police respond, but because ambulances apparently have to take people to a hospital if they find somebody who's inebriated or kind of acting bizarrely, they have to take them to a hospital. They can't take them to a crisis walk-in center. So sometimes what will happen is the same thing, is they'll go into the hospital emergency room and create a fuss. They call the cops arrest them, police, sorry. But if that's the same kind of thing, and if we could get a statute or something that said with some assessment, they could bring them to one of the crisis centers, that's what they're for. So that would be helpful. My other comment, I'm sorry, but the other one I was going to say is that I really think that I've been involved in the RISE program since its inception, and it is a good program, but my concern is what happens after they leave. So not just a discharge plan, but some kind of what we call a warm handoff or some kind of follow-up would really be helpful for these folks, so they're not just, forget the phrase, dumped in their home jail or even ours, but have some kind of follow-up care so that all the good work that they've done in the program has some continuance.
Here, totally agree. I mean, these issues don't resolve on one day, and the next day you don't need any sort of care or follow-up treatment. So definitely agree.
Hey, Allison, this is Summer. I just wanted to weigh in just based on some of the comments. One of the things that the Long-Term Competency Committee has talked about is when we're looking at the community services intercept, how do we make sure that we have equal amount of community services versus what people are getting in jail, so that they're not just getting services in jail, and how do we balance that out? So that is something that's very much on the forefront of the minds of the committee members. So I just wanted to interject that to address some of the comments.
I'm going to go down here and then I'll come back to you, Valerie.
So I'm sorry, am I responding to that?
No, you don't have to. I was just making.
Okay, because I was like, that is definitely still up for debate, and we're trying to figure it out.
So I just want to piggyback on what Diane was talking about. Camille, I'm sure in your presentation you talked about the 207 services and a lot of the 207 dollars that we have invested in, so that in many communities, it's not just the police that go out, but the police are partnered with an embedded therapist, which then helps to be able to de-escalate that situation. And so the state has invested a lot of money in those programs, and maybe that's the presentation. 30 million?
There's 30 programs.
There's 30 programs. So maybe that's the presentation we could have around are those services working? What's the results? Because it's been 3 years now. So there should be enough time to be able to get some data to look at is that programming that we want to expand in additional communities, or if it's not working, then do we want to make changes or discontinue? But it's probably time to take a look at that.
We've just launched 2 of those programs in our region. Be happy to share about them.
But I'm thinking we could share with everybody.
Like a presentation.
Yes, as a part of that.
Ryan, will you share with everyone?
Okay, this is in regard to Nancy's remarks. I'm sorry, Valerie Schleck, Colorado Cross Disability Coalition. This is in regard to Nancy's remarks. It's my understanding that an ambulance cannot bill insurance or insurance won't pay unless an ambulance takes the person to a hospital. And therefore, there would have to be some funding in there if they're allowed to take them to a crisis center or something.
Hang on, I'm gonna get some. And we have time for probably 2 more, and I'm gonna encourage again the parking lot. And I apologize that I keep kind of moving us on. We have so much to cover. And if this committee wants to get as excited as long-term competency, we can go for 3 hours next time.
Hi. And can I mention one thing? This is Allison. I'm hearing both on the chat and there in the group that people are saying we've got some good examples in our communities. Absolutely, the best thing to do is build on successes. So we need to get that information from you all so that we can see what works when we're doing the plan.
Go ahead.
Reina Gonzalez. I had a question for Allison in the sense that I hope that you guys are looking at medications included with the treatment for those patients or for those gentlemen or ladies that are discharged back to jail. The formularies between small county jails and the hospitals do not match. And I've seen time and time again, patients come back just because of destabilization from meds. And it needs to be understood that just because one's found competent by a psychologist doesn't mean the judge has to agree with that competency. And so they can decompensate in jail and then be deemed incompetent again and have to come back. I also want to discuss the jail charges for those patients that are in crisis while in jail. Several people also get charges while in jail, and they're in a mental health crisis. So I think that needs something to be looked at. I was on the phone or Zoom during the last task force or the last meeting for you guys, and I did hear something regarding NGRI statuses. I just wanted to clarify, I didn't agree with what was being said, that NGRI statuses, when it comes to their charges and how long the stay is at the hospital, it has nothing related to the actual level of charges. We tell everybody it's a day to life. It depends on their treatment. It depends on how they respond to medication. Depends on there's a lot of factors to say that a length of stay is related to charges. It depends, and also depends on their risks. It depends on their other risks. Depends on their VRS and how they're found, and just how they move through the system. So somebody with a murder charge can get out sooner than somebody with theft, and I just want to make sure that clarification is in there.
Yeah, so we have not yet looked at NGRI. I think the only comments last time were Robert talking about the makeup of the beds, and maybe comments were made. I honestly don't remember, but certainly those would need to be clarifications once a group starts looking at NGRI. I don't even know that will be our subcommittee at all, because we're just focused on the other end, the beginning end, the competency. So, but as far as the essentially hamster wheel that you're talking about, when you get different treatment in different places, maybe different treatment in state hospital versus in RISE versus in your local county jail, absolutely, that's something we're looking at and making sure there is continuity of care between those settings. First of all, looking at whether or not it's appropriate to send back to those settings, and if the local jail facility does not have the ability to do it, then they shouldn't even be sent back there. Because I totally agree. It's not good for that person to go on that hamster wheel of destabilization, stabilization, destabilization. And it's also not good for the system. We don't get anywhere by doing that. So that's absolutely on the table.
Barbara Drake from Douglas County. I do want to mention that we started a co-responder program in May of 2017 in Douglas County. And our program is a dedicated police officer or sheriff's officer, mental health clinician, and case manager for follow-up in a car on a shift riding together. So it's always the same officer. We have had encounters since we started with over 2,000 people, And those 2 officers have not arrested one single person because they have discretion with the district attorney in our judicial district to overlook things like resisting arrest and some of the other kind of behaviors that you are talking about. So we know for a fact that we have saved over 100 people from being taken to jail that would have otherwise been taken as determined by the police officer. We also are taking people directly to treatment facilities. We have a specialized response from our fire EMS that doesn't have the big rig and the battalion chief and all that show up, and does field medical clearances that the various treatment providers, many of which the same that you work with, accept people directly without going to the emergency department. And we actually have reduced the number of M1s through the sheriff's office, which is our biggest law enforcement jurisdiction, by 7% in the last year. So we have a goal of avoiding emergency department, avoiding jail, and getting people directly connected. So there are models out there that do utilize law enforcement to ensure safety and kind of keep the peace, that do not result in people getting arrested.
Fantastic. We'll definitely build on those successes.
So what I'm going to do while John is giving his update is kind of organize our parking lot structure so that you can things under each subcommittee for us to take back if there are further questions that come up that we just don't have time to get to. So with that, yeah.
So I'm going to speak from the children's point of view here. I just want to make sure we don't err on the side of trying so much to keep folks out of the criminal justice that we protect the children who, in the circumstances that are with the parents, who can get incredibly violent. So I just want to make sure we have balance here and just be the voice of the children right now.
I'm going to give you both of these. All right.
Thank you for that lead-in to the Children's Subcommittee. And so this is John Laukkanen. I work at Healthcare Policy and Finance. And we have actually, we'll be meeting for the 3rd time today, this afternoon. So we have a busy day today on our subcommittee. So we started with looking at a visions and values statements and collecting feedback from our members regarding how we want to infuse the system that we're dreaming of and wanting to create the values that guide that and lead that work. And so we have concluded with actually taking the Behavioral Health Task Force statement of values and their principles. We have edited it a little bit to include some language and some words that conveyed some priorities that we wanted to see take place. Among them would be the ideas of limiting the bureaucracy and layers between a member and services, and so just tweaking some language there. And one area that was particularly important to me was the idea of investment in the workforce. So there was a call out for diversity, numbers, and kind of a general sense of what the workforce looked like. But I wanted to, and we agreed in our statement to call out an idea of investing in that workforce for retention and training and just compensation. So those were some of the minor tweaks we made, and so we'll be obviously communicating that to our task force today. We did add then a child and youth value statement to the bottom, and it's on the screen, but I'll read it to you since that looks very small from here. And that child and youth value statement says, a system that supports children or child and youth centered care incorporates the vision and principles important for all Coloradans. Additionally, it recognizes the unique necessities of developmentally appropriate care, engaging and strengthening families, and creating supports and pathways between the child and adult systems and services. So it was taking obviously the shared values and just making sure that we were responsive and attentive to a child is a unique individual and not just a small adult. So we've also begun looking at a roadmap that is taking kind of how we're going to get to the end of our task. Obviously from the governor's office, there's a roadmap of what we're trying to accomplish. The Behavioral Task Force has a roadmap, and then aligning our work so that we all kind of get to the same place with the same goals in mind and can actually produce a workable blueprint for the governor. So we're working on that, hopefully to have that presented or kind of concluded by the end of the month as we look at how to align this work. We've also been reviewing the source documents and materials that were handed out originally with our subcommittee, and in particularly using the 4-year strategic plan from Partners for Children's Mental Health that included many recommendations from, many stakeholder meetings, many different, a lot of work that was done to reform children's behavioral health. And so we are fortunate enough to say that we're not starting from scratch, and we definitely don't want to reinvent the wheel. And so we're looking at what has been done before us and trying to just move forward with that. So in light of that, and we started our conversations with the idea of governance structure. And how would we want a governance structure to look to help manage, have accountability and authority to provide services for the full spectrum of what children and youth and families need. So that's where we are in our conversation. We're hoping to get to a point of conclusion in that those recommendations by the end of this month. We have this meeting today and then another meeting this month, so that hopefully we can bring some preliminary recommendation to this body by October. And then we are also looking and working to secure a contractor to complete a financial map of the children's behavioral health resources in the state. And that'll help inform our discussion on where is money being spent? Are we taking advantage of all the ways we can pull down federal funds, or how the money that we are spending, is it going towards evidence-based practices? Is it actually prioritizing the things that we want to prioritize in the full spectrum of care, including prevention? And so that's what we're hoping to get this report to inform that step in the conversation. And so these would be the next steps. Obviously, the finalizing of the roadmap, the recommendation to you regarding the governance structure that we're going to put forward, and the contractor and the report that will get that work going. I believe we are hoping to have a report by January if all things work together as we hope them to. And then the next step and topic of conversation would be access, screening, and assessment for our committee. I'm happy to take any questions.
Thanks. This is Diane again. I haven't been to any of your subcommittees yet, but I'm hoping to go today. And I had kind of a gut-wrenching meeting last week with parents who have kids with autism and intellectual and developmental disabilities. And I've worked in the field of that for more years than people are alive in this room. We've never been able to get services for kids that are what we call duly diagnosed. If they're developmentally disabled, they have a mental health problem. Mental health won't serve them because they think DD is the primary diagnosis and vice versa. So I assume you have people on your subcommittee representing families that just really cannot access services at all. And I didn't see it reflected, but I hope they're there sharing their voices, because we heard lots of horror stories about kids with autism that wound up in the criminal justice system as a result of everybody finger pointing that they're not my responsibility. So is that voice being heard?
Yes, we do have a family member representative.
Sorry.
Yes, we do have a family member representative. We do have other people with lived experience on the committee. And then we have been getting reasonable community participation in our subcommittee, and are obviously receiving that feedback and support as well. As a mental health professional myself, I will echo your experience and the insight you're bringing here. And so I would hope as well that we can tackle that as one of the issues among many. So.
Stephanie, someone more thing. Oh, sure.
And apparently, I think the legislature funded some pilot programs a few years ago that have been really successful. And I think the funding is over. And if we're talking about building on successes, I can't remember what the name of the program was. I don't know if Valerie knows, but I want to say it's Strike program or something like that. But I have my notes back at the office, but that's another program if we're going to build on successes that we might want to look at for people with IDD.
Thank you. I just wanted to comment, this is Shannon, on what you were saying as well. I think one of the reasons we're looking at governance is to address some of those issues that like not miss syndrome and people falling through the cracks and who has fundamental responsibility and what does that look like? Because if everyone's responsible, which is kind of what this little graphic here shows, then no one has fundamental responsibility. So I think that's why we're starting with the idea of like governance and system management as who is fundamentally responsible for making sure there is someone that is going to make sure kids aren't falling between state agencies, between funding, and we don't have kids falling through the cracks. So. Good question.
Oh, okay.
Neil Epperson. I just had a visit this week from a parent who has adopted a number of children with various disabilities, particularly mental health issues and severe mental health issues, violence, and really unable to keep the child in the home and putting the other children at risk. And so one of the things that conversation really struck me was that she didn't know where to go to get information about services for her child. That this spaghetti system that we have is very confusing for the parent. And it brought up for me this concept of, is there a way to navigate and help parents navigate this very complex system that we have? And I don't know if the committee is thinking about it from that sort of parental point of view of how do we access these services when they're so complex and confusing?
I'll let Shannon answer since she's right here.
Yes. Hi everyone, this is Shannon again. So one of the things that SB 195 talks about is something like a single point of entry, and that needs to be contemplated and addressed. And so that's already been put through, and so now there needs to be like, how are we going to actually do that? And I think that the idea is that like everybody doesn't have to go through that single point of entry, but if people need a place to navigate, let's give them that as an option. And so it's kind of a combination of no wrong door, and that if you show up with a provider organization can receive services, great, go ahead and do that. But if you're a family member, if you're a primary care physician, and you have a youth or family who's in need, can we give them a place to go? And so the idea is that we do need to create that type of single point of entry to allow the system to be easier to navigate.
Well, I just want to echo and appreciate Lieutenant Governor's comments in terms of the co-occurring disorders. I know I've shared I have 2 autistic children, although one has only hit the scales on 2 of the 3, and so falls between the cracks in terms of what services we can access through the schools. And then also the importance of how the schools and law enforcement, school resource officers are trained in response to it. When my son was 9 years old, he had a autistic meltdown, as I'll call it. And when I showed up at the school, was handcuffed and on the floor, wetting himself because he was so scared. And that in and of itself was traumatizing, which then just exacerbates other issues. So I just want to appreciate and offer that.
Thank you. Stephanie, while you're moving, can I read the question from Zoom?
Yeah. I'm going to give you the microphone though.
And so
I'm going to wear sneakers next time.
Laura from the task force had a question about how the children's subcommittee is looking at governance structures in other states for the delivery of services may be more successful.
Sorry, John.
It's all about where I have the understanding.
So yeah, actually that's what we're doing today. One of the handouts that we had were models from other states. There was a report that was done that looked at in 2017 all the different governance structures that existed. We have some examples that we're starting from, and we're going through how do you set a successful governance structure. These are all the things you need to contemplate. Here's how other states have addressed it. How do we want to address it within our state?
Hi, this is Patricia Oliver, and I wanted to also bring up that we need to pay attention to providers because the system is complicated, very complicated for families to navigate, but it is also very complicated for providers to navigate and understand where to go, who to affiliate with, depending on what kind of services they want to be able to offer to the community. So please make sure to include that little piece there as to that one point of entrance. How do we do that for providers as well, so we can have a nice harmonic, melt there between services.
You mentioned earlier that you're taking into account some of the other work that's been going on, and so I just wanted to mention, which you may already know, there's been a group working for a couple of years on early childhood mental health, as well as maternal mental health, which is, especially for our littlest ones, can never be ignored.
Barbara. Thank you. I need eyes in the back of my head.
Barbara Drake, Douglas County. There's a possible legislation that may be coming out of CCI about mental health for foster children, and it has to do with kids that are in care and then they wind up being in a different way, and the complications about sort of having to start all over again with treatment. So that's just out there, and I think could be incorporated into what you're working on.
I can see all hands from here. I think we're. Is there any last one for John or Shannon? Do either of you have a question to throw back before we move on? Okay. This is really helpful. It's really fun for me, and I know that we don't really have time for me to be talking, but to see how all of these subcommittees work is really starting, even at this really early stage, to really cross over. And we've been talking about the need to probably have subcommittees meeting together to talk about when long-term competency issues fall into the safety net and when children's issues become part of what the long-term competency subcommittee will be doing around prevention. And so it's just really cool to hear all of this. So with that, I'll get the mic to you.
Thank you. Robert Worthwine, the co-chair of this committee, is out of state, so I get to do the presentation this time. And I have to say that I was not at the last subcommittee meeting, but I have really good notes here. So hopefully Summer will help fill in the gaps for this. But so far we've had 3 meetings, and we're meeting twice a month. So yeah, thank you for doing that. We have spent a lot of time in definitions. And so there, just heads up, there's going to be a quiz at the end of my presentation. That is, what would you like us to tackle versus, so what would you like the safety net group to tackle versus what is the work of this group? And that has been something that we've been kind of looking at, thinking about, struggling with, as I say, definitions. What do we mean by safety net? Is that everything for everybody? Is that kind of a thin layer here for the most needy and the most desperate of times? How, if you will, because I think visually, you know, how thick, if you will, how wide and how thick is this safety net? And so we've been really kind of trying to grapple with that. And we're also grappling with language in terms of what do we call the folks in, quote, the system, although we've agreed it's not really a system, but let that go for a moment. Do we call people mentally ill? Do we call people people? And although I don't think we've really come to a definitive kind of person-centered language, which is something we really are wanting to do, something about persons experiencing whatever it is they're experiencing seems to be the most kind of neutral, non-threatening, non-kind of judgmental language. And so we're still struggling with some things here, but let me see if I can do this correctly. This one? Thank you. I am technologically talented. Thank you, John. My new friend, John. So we have a working definition, and again, I'll read it to you in case the writing is too small. A safe, community-based, so this is really important, community-based behavioral health system, notice system, that provides person-centered, patient-driven access to a continuum of behavioral health services. So we've got a continuum here, and supports to all Coloradans, regardless of severity of need or ability to pay. So that's heavy lift. That's a lot given the diversity in the county, of the state, in all the different ways we're diverse, all the different ways. So I won't go into that definition, but that's a big net. So we are working towards a framework, and Summer's going to take this part and walk you through, and then we're going to give you that quiz.
Thanks, Nancy. What I'll just add, if we could just go back real quickly, because I know that Nancy wasn't able to join us at the last subcommittee meeting. So what I wanted to just point out is that we had a really long, robust discussion about what are we talking about when we mean safety net. I mean, I think when we had the meeting that Nancy was at, the meeting before that, when we first brought up definition, the first thing that somebody said was, we have to make sure that we're talking about more than just the uninsured or underinsured. And so from there, we just went out of the gate and went, as you can imagine, all over the place. We heard from other states and how they define safety net, and they talk about it sometimes as, they define it as providers, some define it as population receiving the services, some define it as a set of services being provided. So it's kind of all over the place. And I have to tell you that our safety net subcommittee also went all over the place and ultimately landed on it really has to be something for all Coloradans. Again, regardless of severity of need, ability to pay, where they live, etc. That being said, we also understand that's a really heavy lift. And so I think as we get into this even further, we're probably going to be talking about how do we prioritize and how do we be fair? And at the same time, I mean, we had members from the public at that subcommittee meeting who said, you know, you can't just put us in everyone in a box and say this is who the safety net is for. So I think we're trying to be really mindful of that and really mindful of saying when we're talking about a system for all Coloradans, that's a lot. And so as we get into this work, I think we'll continue to see some challenges from that, which is what Nancy was kind of talking about, the question we have a little bit for the task force here, which I don't think we're going to have time to get into in full detail given where we are in our schedule, but just I'll plant that seed. So just going forward, in the interest of time, that's really small print. I'm not going to read that for you. What I'll just tell you is that as we've been thinking about how are we going to spend our time over the next couple of months, and similar to what we're doing in some of the other subcommittees, is really looking at what's in the legislation that we need to get done. So 222 lays out some specifics of here's what the safety net subcommittee should be doing. I'm sorry, yes, CNET, I'm getting my subcommittees mixed up. But here's what the safety net subcommittee should be doing. We also have expectations from the governor about what he wants to see in the blueprint. So we're trying to lay out kind of a plan for the next couple of months to start to address that, with the idea of by hopefully the end of this year, we will have kind of a loose framework that we can start to kind of poke holes in, share, kind of use all of you as a sounding board, and take a couple months to kind of strengthen that as we go through it. So that's just again, everyone's got these slides, we'll circulate them so you can see them in more detail. So this is the question, Nancy, do you want to pose it or do you want me to?
I'll you were there.
Okay, all right. So as I said before, what would you want to see this subcommittee tackle? So how would we distinguish the subcommittee from this group? What do you want to see us do as opposed to what this group does? Does that make sense? So in so many ways, this committee is going to make the recommendation. So there's a differentiation that we understand in terms of, if you will, authority, but in terms of substance and so on. Jill, you've got your hand up.
Thanks, Commissioner. So prior to this job, I was also a county commissioner in Eagle County. So I'll speak about this looking through that lens. But I love that you landed on the definition of something for all Coloradans. And when I think about Eagle County, which is 50,000 people, so a medium-sized county, but up in the mountains, so fairly isolated. And this goes for a lot of those rural communities west of us. It's been identified that access is such a major issue, and particularly the long wait times for an appointment. And that's definitely what our citizens were experiencing. And I mean, when you're in a rural community, you may or may not have private providers. And so a lot of times people with private insurance still rely on the public mental health system. And that was the biggest complaint we had always gotten, especially with kids. Like, people are really worried about their kids and their kids' mental health. And so they'd come to the conclusion that they needed to seek professional help. They'd call for an appointment, and they were sometimes like 6 weeks out. And we did have a situation that sort of rocked the whole community, where a 13-year-old was cycling in and out of the system and did get delayed in care for that initial visit, and eventually ended up in crisis stabilization endeavor, but eventually did commit suicide, and so rocked the school district. But I would just say it's from outpatient, and being able to just call and get a reasonable appointment time when you know that there's something up. These areas lack detox services as well. So for a long time we were using our jail, which it's not a public safety issue. And then, you sort of have the revolving door because those folks are never getting into treatment. And then of course, all the way to the crisis stabilization, which we know across the state is just such a huge issue, because we just really lack services. I know the root cause of all this is funding, but if you think about your physical health, like, we don't ration that. You call, you're able to get in the same day, or a week or whatever, depending on your issue. But with this system, it just feels like, especially in the rural areas, you're just fighting a lack of options and for folks that really need these services. So I think it should live with your subcommittee. It feels like you have a lot of the experts. It feels like you're going to have to tackle a lot of the nuances of the system, but I love where you landed on that definition.
We're going to go to Zoom real quick for a question up on the phone.
So this kind of echoes the last comment from Becky Gila. She's interested in safety net looking at the significant gaps in services for crisis services, with the 1.4 million lost in funding for a large portion of the Western Slope, and proposes that as a potential topic for an upcoming meeting.
Did you hear that, Nancy? Okay.
Epperson, I would also like for your committee, I know this is a big ask, to really be thinking about parity and what do we mean by parity. We have parity laws, we don't enforce them very well. We see violations of it every single day. What can the committee do to perhaps put more teeth into those parity laws?
This is kind of a question back to the Safety Net Committee, I guess. I think one of my understanding of what this task force can do, and I kind of grown at this, more work, is identify additional subcommittees, correct? That might need to be, and I know last time we did talk about potentially parity being a subcommittee. I'd also like to see if there's, I heard Jill talk about access and on the phone access as well. So maybe it's focusing more on access, and are there different populations that are typically oppressed by not having even further access, that maybe like an equity committee or something like that. I've heard people can talk about disability, people with disabilities, co-occurring diseases, age is something, rural frontier, something like that, that really can dig their teeth into a little bit more, that then allows the Safety Net Committee not to focus on those things, but kind of that all Colorado piece, but to provide that better equity support.
Yeah, and I think that we're hoping, and I don't think we're going to get to it today because this has just been such a good conversation, but I'm hoping that some of these cross-cutting issues that are coming up through all the subcommittees will be what ends up landing here in the task force. And they echo so closely what you told us in the survey around barriers that you want to make sure are being raised. So it's coming full circle. Yeah.
Thanks, Nancy, for asking the question of what else the group can do. But on the other end of the age spectrum are older adults and the issue of dementia. And when you talk about safety net, behavioral health just happens to be that safety net for folks because of behavioral issues. And so it does fall all across the state. Folks with dementia get referred across the community to behavioral health professionals. They get stuck in hospitals and psychiatric facilities where they don't necessarily belong, but we can do a decent job with them. But I would love for the committee to at least look at what we're doing with this population. And again, it may be outside the realm of behavioral health, but make recommendations for what we can do differently with this population.
We talked at the first meeting about the importance of payment models that helped attract providers to the state, that got the right money to the right place, and the importance of access and access all across the system. And Jill's area has built a pretty awesome repository under Steve Halloway. And it would be great if your subcommittee could address both those items because they're critical to be able to handling service to all Coloradans and make sure that we have access. So if we could plot that in your area and team you up with Steve Halloway and Jill's good team, that's everybody licensed, where they are by county, how many of them are seeing Medicaid, which is a great place to start. And then we can determine what do we need to pay, what do we need to do to get the access to all Coloradans, and then it's payment and access to things. So if we could plot that in your area, that would be beautiful, because I don't see an area where we've made that somebody's responsibility.
I'm going to take two more, and then I really want to make sure we get to
on that?
to Camille.
We got to know, hot potato it somewhere, because
I think what
I wrote it down.
okay.
So I think it's a really interesting kind of point. So
It's got to be posted in one of the committees to make a difference going forward.
okay, and I know other people are taking notes too. So we need to just circle back. If it's not going to land there, we need to figure out where that's going to land.
okay. I'm gonna take Deidre's question and one more, and then I want to make sure we get to Camille because she took the time to come today to talk about the PIN study before we have to move on.
This is more of a question than a statement. So I love the equity idea. I love the senior idea. My father died from complications of dementia in 2014, and so I have that lived experience of trying to navigate that. But what strikes me is what was exciting about this opportunity is that we're going to take a fresh look at a system and create newness. And so I realized that when people think, I like that we're landing on all, and I think the only reason all feels daunting is if we kind of use that lens of, we've got to change things, because right now, your typical person on the street probably can't define mental health. They think about it only in a crisis scenario versus that promotion and prevention piece. And if there can be more of an emphasis on that side, not everybody will come to the system on fire. And so I don't know if it's public will, if it's anti-stigma, but just to understand that one of those barriers is getting people to realize that it's okay to need help, and that mental health is a positive piece of it. It's kind of self-care, et cetera, versus, hey, as long as I'm not crazy, I don't need this. Which, you know, in a lot of communities, that's what it seemed like. Take care of your business, keep moving. And how do we encourage all populations to really have a broader, that's just my wondering out loud.
Randy Gonzalez. I'm going to be the voice of a very, very small community of Coloradans, and I don't know where they're going to fall in this task. But for the not guilty by reason of insanity patients, I'll call them patients, housing and actually getting out of the hospital and getting them proper treatment, and the stigma related to them needs to change. So I know this is a huge task for you, and this is a very small population, but I'm going to be their voice right now. So I hope that's something to look into.
I can just respond and say that housing is an issue, no matter which of these. So I'm just going
to respond. Housing is really, really for the folks coming out of the criminal justice system, for anybody with a noticeable disability and so on. I would guess that this particular group is even harder to find housing for. Sex offenders, impossible. Yeah, I completely agree with you. That's the problem about the depth, is that we got a lot of needs, and it's not all just strict therapy. It's transportation, it's childcare, it's housing, access, of course, runs through all that. So yeah, a big job.
All right, I'm gonna again just ask that if there are further questions, comments, suggestions, that they go into the parking lot so that we can take them back, because I know this is really helpful, and that the rest of the members of the subcommittees that can't be here are really eager to hear the feedback coming out of the task force. But with that, I'm going to quickly pass to Camille. She was asked to come today to talk about the PIN study and the work that she's doing, and we'll give her a moment to do that. Hi everyone, Camille Harding. So you have a handout in front of you. It is related to our population and needs study. So the population and needs study is a requirement for our federal block grant, and it's not been updated in some time. And so we have put out a procurement, and health management associates are completing this work for us. And so I think there's a lot of links to the work that the task force is doing. And so the first activity that we've asked them to really take a look at is all the different reports and data that's been produced over the last 5 years. The state has put a lot of investment in those existing reports, so we've asked them to first take a look at that. They are wading through volumes of information and putting it in a really nice grid to help us take a quick look at where we have a lot of information, where we don't have a lot of information. From there, they are going to be looking at all these issues that we've talked about related to housing, equity, subpopulations within the behavioral health continuum, all the way from prevention, because we fund about $8 million of prevention programming across the state, as well as a variety of other agencies, all the way through recovery continuum. So the work that Kristen put together. So they're going to take a broad look at all of that and really kind of map out where we have gaps in the continuum. And then they're going to look at some of the existing work that counties have been doing around. Eagle County's done some really lovely work around mapping out their behavioral health continuum. Larimer, Douglas, lots of folks are undertaking this work. So they're going to be looking at that and mapping out where we have gaps in the system. And so there's a few different steps in this process, and you'll see the timeline at the bottom of your handout. So we'll have kind of the consolidated what the format's going to look like in the next couple of weeks, which I'm happy to share if folks want it. And then what's going to happen is that they're going to do some broader stakeholder engagement as well. And so as the community conversations are happening, we'll be distributing a link to a survey monkey that individuals can anonymously fill out information if they're not comfortable doing sort of a video in front of a large group of people. They can certainly weigh in on where they think there's gaps and where there's different information that needs to be collected. And so that survey and some focus groups and targeted outreach to specific communities and individuals will also occur over the course of the needs assessment. That will culminate in sort of an advisory council to make some final recommendations, and then we'll have a final report that includes literature review, examination of all of our existing public health reports. We're asking them to look at public health and environment data sets, which are really robust, instead of recreate the wheel. And so that'll be done by next spring. And so your engagement and participation is what we're happy to feed this information as it's gathered back to the different committees, and also it would be helpful because this will ultimately turn into the Office of Behavioral Health strategic plans in the next 5 years as well, and where we need to make additional investments with our funds that we have within the office to build out that continuum. So that's it. Thank you. I think the gremlin and the microphone. Oh, there it is. We are going to put questions about the PIN study in the parking lot, just in an effort to close on time. So Camille, we can funnel questions back to you and email them. I want to turn to members of the public to make sure you have an opportunity to ask questions that brought you here today or things that you heard today. Thank you for taking the time, and we'll do that now.
Hi, my name is Ann Noonan. I've been in the behavioral health field for 35 years. And so I wanted to say a couple things just in terms of, I want to echo what Brian said about how easy it is to get caught up in solving problem by problem, little problem by little. Not that they're little, each one is huge, but to solve it individually. And what we really have the opportunity to do with this group, having the heads of all these divisions and agencies and organizations, is really to reconfigure the system. Many of the problems that we're talking about come from just organizational barriers that I think we have an opportunity to really look at. For example, we talk about behavioral health, but we really have never gotten to full integration of substance abuse disorder and mental health. I hear the language popping all over in the room. We are not fully integrated there. And when we talk about healthcare, we're certainly not integrated into full healthcare. But healthcare assumes that behavioral health has their act together, and we don't yet. So just we're making good progress on things like bringing the organizations together for licensing and registration purposes. But just one example, withdrawal management units that don't have medical oversight can be next door to an acute treatment unit that does have medical oversight, but they're near the twain shall meet. The clients can't mix. The doc on this side can't prescribe meds for somebody on the other side of the firewall. So those kinds of things are things that I think this group really has the power to start taking a look at. And I love the subcommittee idea. I want this task force to really focus on the big picture. That would be my feedback.
Hi, my name is Steve, and I'm a recovering benzodiazepine overprescriber. And I mention that because that is a very big issue that a lot of us in medicine have really neglected and so forth. So I'm Steve Wright. I grew up in family medicine, been doing addiction medicine for 32 years, medical pain management for 15 years. And we have lost sight of this because the vast majority of individuals that are challenged by benzodiazepines go under the radar because it's not addiction. And it's really important to address this specific issue. It has recently come to our attention in particular because a recent study provided by the CDC indicated that 52% of individuals with opioid-associated deaths have a benzodiazepine on board. So it's a significant factor, but it's not just that. There's a universe of individuals that are taking benzodiazepines from us that is not guideline supported. So for example, it should not be used for PTSD. It should not be used for OCD. It should not be used typically longer than 4 weeks. So I know there's a lot of issues here, and I echo everything that everybody has said, particularly, and in terms of the integration issue, very, very important, something that we should study, by the way. But I really want to add this particular issue because it's relatively occult. We don't see it very well, and yet it's enormously important, both for our co-prescribed opioid benzodiazepines, but also those individuals that are really challenged by this, that are using benzodiazepines monotherapy, and it really amplifies the concern that I have that alternative treatments, non-medication approaches really are absent in terms of access for our patients.
Any others before we move on? All right, well, as you can probably see if you're looking at your agenda, we ran out of time today. And I'm pretty comfortable with where we landed because I think it sets us up really nicely, and I'm looking for Summer. She's moving around just like I am, for next steps and how we might be able to do some more kind of in the weeds work between meetings, and what we can do to set up the next meeting to really start diving into what is this task force going to do related to what the subcommittees are going to do independently.
So I will say I think today's conversation was really rich. And at the same time, what I'll say is that what we had hoped is that all of you would walk away today getting really excited because we're reading into the meat of stuff. And while we had a rich discussion, we didn't necessarily get into the meat of what we need to start doing. And quite frankly, we could all probably sit in this room and talk for the next 8 hours, and we're not going to have time to do that. So I just kind of want to prepare you that we will sit down, kind of look at the roadmap for our work and what we want to accomplish, and start asking everyone to do more work in between meetings. We're also thinking about the idea of, I know there's been some thoughts thrown around new subcommittees. I will tell you, I'm hesitant to go there. What I would suggest maybe is that we consider working groups across the subcommittee. So for instance, I'll just use example workforce, it touches almost everything that we're doing. So do we have a workforce working group that is a combination of the subcommittees and task force members? So we're thinking about something like that. I think we will circle back with you and kind of have some more concrete suggestions, but this is just your warning of get ready. Now we're going to start really doing the work. Now we're rolling up our sleeves. We have a lot to do. I wake up every morning and one of my first thoughts is we are one day closer to June of 2020 and we still have a boatload of work to do. And so we can't do it alone. We have to engage all of you to do that. So this is just your forewarning of we can have meetings like this that are really great and they're rich conversation, but we also need to have meetings where we're doing things in between our meetings as well. So this is your forewarning. Get ready, get some rest. We're about to get busy.
Did you want to float 3 hours too?
Yeah, I
Yeah.
would suggest that.
Yeah. Question.
I'm wondering if we could get the schedule of when future meetings are. It's really hard to make a commitment to attend meetings when we don't know when it's going to be.
We are working furiously on where the meetings are going to be. The meeting schedule should be, we have put out meeting invitations. We will make sure to put those in an email so you get that in addition to just the meeting invitations.
Just schedule it for the whole year.
We have them scheduled through
January.
March, or I thought it was March. Anyways, yes, we will get that. We will get that out.
I think the challenging part is trying to juggle executive committee availability to get them scheduled, and we are trying.
I mean, you have no idea. That's what I wake up thinking about, is trying to get all these rooms scheduled and people, because I understand that it's really hard when you don't know in advance. So know that we're working on that.
Yeah. And we are thinking about the next meeting making 3 hours.
Which meeting is that?
That is October 2nd. It's right now scheduled from 1 to 3. I don't remember.
We are working on space.
Yeah.
And again, we have exhausted free space across the Metro Denver area. If you have thoughts about other places we might be able to hold these meetings, please let us know, because we are banging on doors for people who have spaces with microphones.
Yeah. So we'll float the idea of making the next meeting Wednesday, October 2nd from 1 to 4.
All right, I'll give it to Michelle to say
Well, do we
farewell.
want to decide that right now? Because you got people, they got the calendar, we need to.
I mean, I think does anyone object to doing that? This might be an easier way to do it. We're going to extend October 2nd to 3 hours.
For people driving in from rural, it makes more sense. I like a longer meeting to feel like it was a good use of time. And I like the idea of it being a little bit more in the middle of the day rather than right at the beginning of the day or right at the end, just because I left Denver to stop.
Yeah, we can absolutely do that, but you guys, we can't save you. We don't have budget to do that. So bring your lunch and we do midday, and I'll remind people. I'm not offended if you're eating while we're here, but.
Thank you all for all your time today. I do want to encourage you to, before you head out or before the next meeting, spend a few minutes getting to know other people in the room. There's a lot of knowledge around this table and the people here from the public. And a lot of your education can come just from informal dialogue. So I really encourage you to do that as well. And thank you everyone for coming, and know we're available if you have any questions.